Hi, everyone. Welcome to our session on the transformation of care in the age of COVID-19. I am Nikita Sharma. I'm the Vice President for Growth Strategy and Marketing for Innovaser. And we have a very esteemed panel here with us of Dr. Randy Moore, Dr. Omayra Mansfield, and Ms. Ashima Gupta from Google. Why don't we go around and do some quick introductions? Dr. Moore, do you want to get us started?
Certainly. Well, welcome everybody, and thank you for being with us. Again, my name is Randy Moore. I'm an internal medicine physician by background, started in academia, lasted about 9 years and seemed to go on a series of 9-year stints from academia to working for a Fortune 500 company to running a telemedicine company. And then for the last 6 or 7 years inside of large health systems, again, with a combined passion all the time of how do we re-engineer models of care, particularly with the use of analytics and technology. Thank you.
Dr. Mansfield, do you want to go next?
Sure. I'm Omayra Mansfield. I'm a Chief Medical Officer with AdventHealth at 2 of our campuses in Apopka and Winter Garden. I'm also a practicing emergency medicine physician. I've been with AdventHealth now for about 8 years, and prior to that, prior to going into medicine, actually was in healthcare administration in a variety of finance positions. COVID has definitely reimagined the work as a chief medical officer and as an ER doc, and so I'm very much looking forward to the conversation we're going to have about transformation in healthcare.
Great.
Awesome. This is Ashima Gupta. I lead our healthcare strategy and industry product and solutions for provider sector in Google Cloud. Prior to that, I'm ex-Kaiser Permanente, been technologist, computer science, and health tech, right at the intersection of it. At Kaiser Permanente, I was responsible for digital health incubations and launching mobile applications. Prior to that, I come from the fintech. And now in this brave new world, we're all reimagining, Dr. Meyer, good to say that we're all reimagining what the future looks like for our relative jobs and our initiative that we will be taking on. So thank you for Nikita and team for inviting us here.
Thank you all for being here. So let's jump in. So we'll do about 30, 35 minutes of sort of our panel discussion, and then we'll take some questions from our Q&A feed as well, and talk about some of the other topics that come up along the way. So jumping in then, would love to hear from each of you how COVID-19 has impacted your organizations, and particularly what are the key changes in operations or care delivery that you have had to make?
Sure, I'd be glad to start. My role inside of Franciscan Health, we're about a $3 billion system. I'm Chief Operating Officer and also Senior Vice President of Health and Care Solutions. Got a lot of the non-hospital operations report into me and all of our physicians, practices, et cetera. One of the reasons, one of my responsibilities is to help lead system transformation from, if you will, fee-for-service to value-based care. And certainly what COVID has done is rapidly accelerated that journey. As people are saying, the genie's out of the bottle, and what people didn't think was possible last year is happening in a very, very significant way. To tell a quick story of how things have changed, we had a lot of resistance to virtual care, which is a strong part of my background, for all the normal reasons that you would expect. And once COVID hit, we went from probably single-digit number of virtual visits per day to several weeks into the pandemic, we were doing 3,000 plus visits a day. Fortunately, we had laid the background, the technological background, and done some of the pre-education and work that allowed us to ramp very quickly. But it wasn't just doing virtual visits. The other thing that happened is we had to reimagine how we delivered care. So, for instance, with PPE being restrained and just the stress on personnel, several groups started a program inside of our systems looking at the ICU and COVID patients, and could we create a new level of virtual ICU? to where not just an intensive care team would be available to see the COVID patients in the ICU, but what about putting together a cardiologist, a pulmonologist, infectious disease, pharmacy, nursing, social work, discharge planning, et cetera, all in one room at one time, and a hospitalist and nurse at the bedside connected to the patient. And now, instead of individual rounds, we had an immediate move towards team-based care. Real-time, talking to each other, educating, putting the issues back and forth, which almost always resulted in a change of care. So it's that type of change that's been accelerated, I'd say, by at least 3 to 5 years compared to probably where we would have been. So in terms of value and moving to value, we have no choice during the pandemic but to segment patients, to use more analytics, to use more technology. And it's really changing our perspective. I think we'll carry with us on a going forward basis. I'll stop there and allow others to share.
I'll chime in here. I agree with everything Dr. Moore said. I think we experienced very similar changes in how we embraced particularly virtual medicine and how we communicated with the people that we serve. The other thing that I would add in terms of the operations piece, it definitely made us more aware of some of how we consider, particularly with purchasing certain equipment like PPE being the perfect example. Just-in-time ordering really wouldn't suffice, particularly when some of your sources of key equipment became scarce. And so that's something that made us reconfigure moving forward. What is the equipment that we should always have on hand and have some supply of? The other piece that I think is a takeaway in terms of how we change our operations is that, unfortunately, I think this is the nature of medicine over the past several decades. We have tended to become very bureaucratic in decision-making, and also in how we even consider therapeutics and medical interventions. And certainly with information change being so robust and just the evidence from just medical publications, it was so overwhelming, just so daunting and so quickly evolving that we had to think about how do we adapt more readily? How do we become more flexible to changes in treatment, because obviously our patients would benefit. And I think we ended up moving the voice of the physician forward rather than it being third, fourth, or even 10th in line for decision making. And we elevated a core of physician leaders to become part of the leading committee and the leading stewards for how information would be utilized. We actually took physician leaders that were already in spaces within the organization and identified where they had expertise. So for example, we created a scientific subcommittee with subject matter experts who were solely responsible for keeping up with the information, identifying what we could move forward with and what we wouldn't, and had them be accountable to look at things within days rather than within weeks, and source all of that through a command center. So actually looking at this as a disaster where we would have a command center, but having it actually be an ongoing command center. And actually that command center is still up and going with an incident commander, so that we have a one-stop shop for decision-making and then also for dissemination of communication. That ultimately impacts the care that we deliver because we can feel that we are at the cutting edge of the information that's in front of us. Because I think if we had fallen onto historically how we perceived and adapted to changes, we would be way behind the curve and subsequently our patients would have suffered.
And just to add to that, a very similar journey, but being on the technology side, our focus was how do we serve the industry and our customers at large. So we had a cloud-wise intake triage process where our customers were reaching out to us, and we were, again, it was pretty surreal to see entire company come together as one unit. And we had a war room also, but virtual, and triaging of the requests. And one thing that came out, Dr. Moore, very consistent, the virtual care came as a top request from globally that people were looking into, and the solutions were spun up overnight. And healthcare industry, with the efforts of all of you, rose up to the occasion, and virtual care became a reality. And having come from Kaiser Permanente, like it used to be, everyone was talking about telehealth and virtual care. So it was very gratifying to see that overnight. That means things were possible before, and what COVID did was brought all the stakeholders together, that decision making, and moving past the the inertia. The second thing I'll say at the personal level, we always say that technology comes in between patient and provider care. And I'll give you an example. During the peak of COVID, Mount Sinai Hospital, they had ICU and the nurses had to don in the PPE to get into the room. And there's a human element as well when you're walking into the ICU. So we had Google Nest installed as a nursing station. You talked about the common rounding. It became a way that nursing station became virtual outside the ICU, and people were doing that monitoring, kind of remote monitoring within the hospital, but outside of the ICU. So to me, technology it kind of humanized that experience when there's fear, when there's uncertainty, and virtual became the only norm and the only way to make that connection happen. We also saw family members meet their, final goodbyes or the very first hellos, leveraging technology. So again, always heard that technology comes in between, and this was quite the opposite way to say how tech can humanize those experiences. Now, above and beyond that, I think we also had to recalibrate a lot of our technology roadmap, and virtual care, as an example, telehealth became, and we did some investments with Amwell on that because the needs are changing, the needs are shifting. There's a virtual first pivot that we're all experiencing in many, many different directions.
I'd add that I think, building on what people are saying, one of the things we saw also was the need to have highly functioning teams. And it really pulled teamwork together, I think, which several folks have already said. But not just a team, but a team of teams, kind of coined in the military, that it's a new world, and we need to have teams that were both functioning individually but collectively. And critical to those teams was the availability of real-time information. We quickly cross-credentialed our providers across our dozen hospitals and regions because the different markets had different COVID demands. And we had to do everything from workload balancing of moving our coworkers around to different sites, as well as moving patients as some of our hospitals actually filled up. So it really introduced many things in terms of moving systems, I think, to have more systemness. And something that all of us will take with us. And then again, the backbone of that is you've got to have shared information and a way to communicate on a much more real-time basis. And as you shared, overcoming bureaucracy. We had the luxury of long-time decision-making, which this showed us. And A, we didn't have it, and B, we could work without it.
Yep, absolutely. And, speaking of that, Nick, a lot of this requires, obviously having the right information in the right place. And how did sort of having the systems you have or the data that's accessible or maybe the lack thereof play a role in this? And how did your organization kind of get around that at rapid pace as you were forced to do in this situation?
Well, I'll start again. We were fortunate that in the last 18 months leading up to, or 2 years leading up to this, we had really started to look at what did our infrastructure need to look like from an IT perspective to have the backbone in place to become that more real-time responsive system. So in many ways, we're making the investment, but we didn't have a lot of demand to change what we historically had done. And then COVID did bring that on fairly quickly. So we also, I did mention, we immediately went to thousands of coworkers working from home in situations that probably before a lot of management leadership didn't think would work. And not surprising, as some other industries have already learned, that some of our coworkers didn't become less productive, they became more productive. And then also some of the people who went home, who thought it'd be really cool to work from home all the time, were somewhat anxious to come back to work some as well. So the IT enabled us, if you will, to make it less important where people were, but the IT was absolutely critical, which we saw not just for our own internal systems, but I'm sure many people around the country experienced just bandwidth shortages, as everything from kids in college to kids studying at home, to everybody being remote, and all of a sudden there just was not enough bandwidth out there. So a lot of companies, a lot of infrastructure got stressed at the same time, and I think it's helped us all grow to where we need to be for the future. It does show us, I think, too, that we need more. And in our practice, for instance, we had people who could dive into virtual health pretty quickly and do it well. We had others that couldn't. Same with the people we were serving, the patients. And it showed us how much is not just technology, but how do you prep for the technology? How do you help people understand how to use that in their world so they can take what they do today that requires in person and complement it with care and services that doesn't require us to be in person.
It seemed to challenge some of our assumptions. It's funny, I think about just a particular population that you would have assumed, an older population, 65 and over, how could they ever adapt to virtual? Well, in fact, I think we had some assumptions that in some cases were actually terribly wrong, and they adapted quite well. And in fact, not only could they access technology easily, they preferred it in some cases because it was easier than trying to get to, for example, their doctor's offices. And it actually allowed for frequent touch points, more frequent than otherwise traditional medicine would have allowed for. So I totally agree with Dr. Moore that this has put us to a space to move us into the future, because in some cases we were actually wrong about what we thought would have happened. The other piece I would add to the importance of the data is that fortunately, I think as a company, we had already been on this journey of transparency and easy access to accurate reporting of data. And the other piece that I think was a God-given gift was that collectively AdventHealth had really gone into this one brand role in early of 2019 rather than having all of our myriad of hospitals across the country. So we were already thinking, I like the word systemness that you used, Dr. Moore, in the sense that we are one system when we could leverage our resources. And so having transparency of data, so for example, how many ventilators did we have in our system, but where were they located and where could we better allocate them? So for example, when Chicago was hit pretty hard and we have hospitals there, where could we move ventilators that maybe Florida didn't quite need to that area? So leveraging the data that we had fortunately validated earlier on through the dashboards that we had created ended up being very worthwhile because it allowed for real-time motion. And then the other piece that we continue to figure out is what is the place for certain pieces of data? Because I think the other thing we learned is you can create a dashboard for anything, but it doesn't mean it actually generates valuable data. And what's important in the moment, and when do you sunset something that actually is no longer important? I think traditionally we get into a habit of getting information but not continue to question, why is this useful? And now I think that becomes part of our natural progression of the questioning is, when is this data useful? Is it still useful? Can we sunset it? What do we need to move on to? And I think that both technology and how data is viewed has definitely evolved just in the past 6 months.
Dr. Mansfield, you said something I think is very important about, people could do this, they could actually do virtual experiment, but the role of data, not just logistics in terms of our supplies and technology, et cetera, but one of the things I think people are going to continue to see that virtual introduces is it's not just that we can do a virtual visit, but compared to needing to be in person, that visit can be much more timely. If you think about it, I used to be chief medical officer running a university emergency room. And I remember back then of thinking, gosh, I'm seeing a patient, it's Thursday. If I could have seen what happened on Tuesday, they wouldn't be in the emergency room. And our system never worked that way. Well, I think COVID is teaching us to work that way. How do we create full patient-centered care continuums and complement that with person-centric health continuums? Keeping people healthy, using technology, using analytics to move upstream and see people before they're crashing into the ER.
And good point, Dr. Moore. Like it takes almost 100 minutes for a physical visit. And not many, and as a busy mom, I can tell you if I can get a virtual option to get a refill, it's most welcome.
Yes.
I think the other thing I would say from the building on the point, Dr. Omayra, you were making we were all now, whole world is excited about science, about data. I think we all saw that real time it unfold. It has put all the world leading researchers, practitioners, technologists, all working on the same cause. And I think to me, that's a big shift in how we will view science and data going forward and leading with science, leading with data. And also the data interoperability, the topic very near and dear to my heart, is what COVID has highlighted is the access to timely data, be it the PPE, ICU, bed availability, be it my labs, my pre-existing conditions, my first encounter, did I go to an ER before or an urgent care? I think that data in healthcare, as we all know, is not still activated. It's still in siloed. And we are seeing now people understanding at a greater depth why there needs to be that data access and the new rules that are coming out to help with that data availability via APIs and activating of that data in the clinical setting for serving the patients and for serving the physicians better.
So I guess what I'm hearing is, it's not just that COVID has accelerated kind of the shift to embracing technology, which was sort of the need of the day, but is also pushing towards, what probably on your technology roadmap was further down and like, the modern technology or the transformation. It's like, we need that now because our current systems, we've accepted them, but they've probably not served us the best and are not giving us the best insights. And we could, the newer technology is available, and so we should probably, go ahead and rapidly adopt that. Would love to know a little bit about, obviously there's been a bunch of changes that have been made in care delivery, and you've had to rapidly make them because of COVID. But which of these things would you say, what are maybe the 3 to 5 things that you think will carry on beyond COVID? So they will become an intrinsic part of how care is delivered, even when we're not in a pandemic, which, hopefully should be soon, but, fingers crossed.
Well, one of the pieces that I hope it's not just inside of health systems, but as we all know, the government's put a lot of regulation relaxation in place, and for instance, created parity to be able to say, we'll see patients virtually. When you see patients virtually, we'll pay you at parity. That was a major impediment to a lot of virtual being done. And with that, along with the need, I think what's happened is, from a more global societal issue, we are seeing some of the cracks and flaws in fee-for-service, on-site, face-to-face medicine is the only way to get care for your sickness. And now we're seeing that we can do things differently. With it too, we start thinking outside the box. As our hospitals have increasingly their beds are filled, can we move a patient out of the hospital sooner in those last 1 or 2 days of convalescence? Because now we can follow them virtually, potentially with the same team that was following them in the hospital. Or somebody presents to the emergency room. Historically, because of lack of follow-up and continuity, our only option was to admit them to the hospital. But now, again, can we send them home and care for them alternatively with virtual and home care combination? But if we're to do that, as a society, health plans, government, we all have to come together to say, if we're really putting the person at the center of care, how do we recreate the ecosystem to actually make this work in a sustainable model? And I believe that we have and we will, and what we will find out is we can significantly decrease cost by becoming more efficient, more effective, and looking at the person more comprehensively across time, but also unleashing the power of our teams and our institutions to be able to combine more technology, more analytics, integrating and changing the operations process, looking collectively at operations re-engineering, financial re-engineering, and care re-engineering, and making sure we're focused on health at the same time we're focused on sickness.
Yeah, to add to that, I think we also saw, and going back to the health disparity angle, I hope and I think we've seen as a society the broad disparities that exist, be it moving forward. You mentioned patient at the right at the center of it. So many social determinants of health we had talked about, into social economic status, physical environment. It does have a considerable effect on the outcomes. And moving forward, as the lessons of COVID-19 are learned, as we design as technologies, as the systems, the new digital infrastructure, we need to account for that both in how we approach scientific discovery, how we support public health, and how we build that infrastructure post-COVID. I think that needs to stay on. On the virtual, I think it's much more going to be hybrid. Dr. Moore, to your point, right now, right care at the right setting for the right modality. I think that's a trick. That care navigation still needs to be built. Maybe Dr. Mansfield, I'll love to hear your perspective. That's how I see, it's kind of hybrid. I gave an example. We don't call retail banking. We call it banking. Why do we call, or telebanking, right? We do it the banking, right? Is it bank or is on the online? Why do we call it telehealth? It's health, and these are different modalities, whether you walk into the clinic or whether it's virtual.
Absolutely. I would say that we have been pushed to change the way that we perceive clinical practice over weeks, what would probably take you a few years to adopt in terms of your clinical strategy. Just as an example, I have personally discharged patients home with vital signs that if you'd asked me back in February, never in a million years. But it was in large part because of the ability, as Dr. Moore pointed out, to continue to do monitoring with home monitoring, even sending patients home with pulse ox, their own thermometers, and even using a technology via an app to have 3 times a day touch points. We were forced into that scope and honestly out of our comfort zone for those of us who have practiced for a long time and have our set way that we practice, but it was also out of pure necessity because of a concern for appropriate availability of the resources for those who would be most critically ill. And the beauty of it has been that doing this actually in a very thoughtful and evidence-based way and collecting data has demonstrated that actually this can be very successful. It does actually save money, and the patients actually do quite well. And candidly, who wouldn't prefer to sleep in their own bed and be in a hospital bed for 1 or 2 days? The other piece I would add, and I totally agree as well with this concept that we have seen, COVID has really put under a magnifying glass the disparities that can occur depending on your socioeconomic status, where you live, what part of the country. And what I've also been very happy to see has been that in the medical field, we haven't just looked at that and identifying populations that may be at risk, but even how we're pursuing vaccine trials and making sure that we're incorporating some of these populations that otherwise would not have been represented very well in the big scheme of a population to be considered for a trial. So that's been a beautiful thing to see. The last piece that I'd like to add has been this new focus on the mental health of the community, but in health workers as well. It's unfortunate that it took a pandemic like COVID to bring to the forefront in a more clear way the gaps that exist in mental health availability for everybody, but then also just the general pressures that our medical professionals feel every day. I sincerely hope that that doesn't go away because that existed before COVID. It just became less taboo and more common speak for the general population. And I hope that that continues. The general awareness that we need to be mindful of the mental health of those who provide care in really difficult situations every day, and they've done so for decades.
I'd like to build, and a kind of a final point too is what it's really helped, I think, a lot of us understand is we've had a health and sickness system that's focused on the provider, the health plan, and not so much on the person and the patient as far as being put at the center. Most industries learned a long time ago that the customer, the ultimate customer, is where value's got to be placed. And it's not around, did you do a good surgery? Did you do a good unit of care? It's what's the outcome and what's the quality of life? And I think what COVID is forcing us to do is say, how do we use what really are our limited resources to focus on the population and people to optimize the outcome? And that's the fundamental shift we have to get into is how do we begin paying for outcomes of individuals and populations as opposed to units of healthcare that are delivered in some specific way?
Yeah, and really dovetailing on that, and these are some of the question on the chat as well. Do you see a fundamental shift towards having more value-based care type setups. And you guys have all talked about having, care teams even within the hospital now. And as you said, being more preventative and being more thoughtful about when you can discharge a patient, if you have better, technology tools, et cetera, to monitor them and do what you might have done in the hospital. So do you see a bigger shift towards that? Because it seems like COVID has revealed that, the fee-for-service mode of doing things doesn't necessarily work in this way, because people have a lot of complex health issues going even without the pandemic, and then also things like surprise billing and all of those things are kind of exacerbating an already bad situation. So would love to hear your thoughts on how you think payment models might change.
I'm hopeful that what has occurred is the impetus to really accelerate value-based care, and for people to see the need to work together collectively as an integrated versus a competitive or conflicting ecosystem. Health plans, providers, our communities, our employers need to come together. And again, COVID has shown us we can do that. It's forced us in many ways to do it, but I think most of us have seen that in doing so, the value we can provide is even better, and it has to be better. So I do think it's a takeaway, and I want to reinforce that. I've talked about virtual several times. Beginning 20 years ago on stage at telemedicine conference, if you want it to work, don't pay for it, which was kind of a tongue-in-cheek, but it was meant as don't create another silo. It's about care. It's not about virtual care, ambulatory care, inpatient care, home care. It's about care. And then if we think about it, it can't be just about care. It's got to be about health. Because if we can maintain health, the care needs drop, and it's much more efficient and effective and higher value for all of us.
Very well said, Dr. Moore. I think I really like the focus from care to health and the total health from a patient's perspective. Again, from the technology perspective, that means this was always possible to combine all the data points from a patient perspective, but that impetus wasn't there. And we saw the unprecedented collaborations, be it different competing pharma companies working together, different hospital systems coordinating the PPEs even across our boundaries. So that cause and that common thread, I think, brought everyone to the same table, and hopefully that will be the end of the fee-for-service world. Or as we look into value-based, can we do it for the keeping patient really at the center? And technologies does exist, as COVID has shown us.
It really also highlighted that where a building sometimes doesn't matter anymore. Certainly, it's still important to have hospitals, but I have to wonder if this is a turning point in the healthcare delivery model, which is, as we look forward into the next 10, 20 years and we're planning, the question begins, what is the space planned for? What could it be used for? But then what could it alternatively be used for? And I think that's a question that we took it to various levels. So for example, within the hospital, my hospital, at one point we had to look at how many beds could we potentially make ICU beds. So that's going in one direction on the spectrum, right? How many spaces could you put a patient in a bed or in a chair, because we thought we were going to get this influx of thousands and thousands of patients. But then when you move on the other end of the spectrum, as we start to realize that there is something to be said for care that isn't provided within the walls of the hospital, then what can that space be used for? And how can we become very creative in using that space in a way that provides that whole person-centered care? So I think just moving forward, it probably has changed our historical perspective of the classic healthcare model and the classic healthcare just building to more of a, how does that adapt to a human being, and not just in an acute care crisis, which, as has been previously mentioned, when we think about the social determinants of health, we know that's only 10%, and the other 90% has to do with everything else that affects the human being.
Yeah, especially to building on your point, like Dr. Feinberg, who leads our Google Health, and he always challenges by saying this: for the most chronic condition, the inpatient is a failure of outpatient, meaning the reason you are in the hospital. Outpatient is the kind of failure of care at home. and at-home care is failure at the community level. So health is not just inpatient, outpatient, home. It needs to be really dealt at the community level, and that public health has been now the focus. I think that the focus on public health has never been there to the level that it needed to be, and I'm hoping that, and we'll be curious to see your thoughts. Your daughter was cute. Just to see that becoming mainstream as well. See the levity.
Yeah, I think your comment on the hospital was key. I looked at it, the hospital in the same way. It should be an institution going into the future where if we have to physically invade somebody's body, or just there's such an intensity of need that could not be avoided. But if you will, our hospitals were built pre-technology that we have today in order for expert teams to come together to deliver that team-based continuum of care to somebody. Well, with technology, the team can come together just as we've seen inside of COVID without reliance on the physical structure. And we can pull more people in on a more timely basis, including from the community and the patient's ecosystem. And so I think we are going to, in fact, we must embrace how do we use our resources differently. We cannot use hospitals on a going forward basis to care for people the way we historically have. It's bringing what they need just in time.
Yeah, absolutely. And Ashima, just, from your perspective, what you're hearing from health systems, how has this changed their, technology or digital transformation journey? And, at the same time where there's this great realization that we really do need to invest in modern technology because there's so much more we can do. And in fact, right now we have to do. There's the financial pressures that COVID has created for every health system. I mean, health systems, as it is, in the various healthcare segments was probably financially stressed to begin with. And then, this has just exacerbated the situation. So how, Ashima, I guess, what are you hearing from your customers? And then what do you think technology companies can do to help providers really embrace technology given the current constraints?
A great question. And as we work with health systems, payers, life sciences, I think, especially for the provider, the pressure that COVID has put for the already thin operating margin is pretty evident. The innovation budgets are still there, but it's forcing the conversation on more optimizing operations, optimizing care delivery, and investing in technologies like care delivery, but more on the digital side. The level of the unsustainable level for America's hospitals from the operating margin, it's a concern. It will remain the concern. And to add to that, you add new cost pressures stemming from keeping extra inventory, usage of expensive PPE, complying with the different local health policies, depending upon the wave of of COVID. That purple tier, red tier, all that is already. The operating margin within, you add all this pressure. So it's changing the conversation on the optimization of operations. I see 4 areas that are important or they surface. There's concept of this digital front door. This used to be a concept, is now becoming much more forefront, which is combining the telehealth, but digitizing the patient journey. And we saw during COVID, the inclusion of conversational chatbots, the agents, where the first contact is not on the call centers because they were all receiving 10x times the calls than the agents that were there to receive the call. So the entire digital journey, starting with a conversation chatbot, leading to either a telehealth visit or a hybrid visit, I think that's one area that most are figuring out. The second, on the operations side, I touched on that, the shift to remote, be it, not just the healthcare employees, but the IT employees using collaboration tools, which now it has accelerated that. The back office automation, we're seeing where many hospital systems had to furlough employees. In what can be automated? How can we aid the human productivity? So we see a lot of medical coding, claims processing, more automation on the revenue cycle. Those projects have come kind of forefront. And the fourth one I think we all have touched on is this enterprise digital data platform. Like they are really looking into one common way to make sense of the data, get glean insights for the patient care. There were many, all these initiatives are already underway at different level of maturity. It has now become forefront, and it's no longer like innovation. Innovation sometimes in the healthcare setting can be a tricky world because these are side projects you will see end of light of the day 5-7 years from now. But this is really core innovation from the systems perspective.
I think one of the things we've learned too is that the system can't just do sustaining innovation. We've got to do transformative innovation. But transformative innovation is often there's some future state way out there that we, for then many folks, is like, how do we get from here to there? And I look at it like a physician looking at a patient. The best thing you can do working with somebody is find out where they are at, what's important to them, and show what may be possible. What they've got, you've got to create the journey with them. And so from a technology standpoint, the similar takeaway I have is the more of us can come together to really understand where each system is currently functioning and to help build the roadmaps to help people go through the journey to get to the future that we all have to get to together. Phenomenal amount of intellectual capacity out there in future states. But let's tap into that also to go together and actually get from here to there.
Yeah, absolutely. And, I guess one of the quick questions has been, as you are making these changes and maybe even the care protocol somewhat, how are physicians dealing with kind of the typical rules or legalities that, surround these things as you're changing these, rapidly?
I think if you always let doctors make sure that they're aware that in the end, their clinical acumen and their clinical decision making supersedes anything else, and making sure that they're still practicing with autonomy and supporting their efforts. I think COVID has definitely taught us that we thought we did a good job communicating, but in reality, we probably were doing a terrible job in communicating. And so it made us refine not only what we communicate, but how we do it, who writes it, and how quickly it's disseminated. But in some of it, particularly when it comes to the actual, really the way we were required to change our practice out of pure necessity, it was about, again, being, I think, physician-driven was critical. Never having someone else who's not at the bedside impose, this is what you're going to do, and instead really seeking that input, being collaborative, hearing what they had to say, and taking that and then using that to model the best practice. So again, going back to the example, never in a million years would I have thought I'd discharge a certain patient. But then when someone said, well, what if I gave you a pulse ox and you could monitor their home O2 sat? What if I gave you this? What if I promised to check in with them 3 times a day? What if I showed you that this process did work and it didn't have breakdowns? And what if we even put the app on the patient's phone before they ever left the ER? Well, then sure. Then if you can do all that, show me you can do that. And then I'm okay with that because I'm still owning the decision making as to I get to pick which patient is appropriate for that journey. And that's what we did. So I think it's making sure that we never have a non-clinical person telling a clinical person what they'll do, instead listening to help me get to this endpoint and do it in a way that you feel is safe for your patients. And I think we all understood the dire situation that we were looking at, and it really forced us to come collaboratively to the table to figure it out. And subsequently, I think the ingenuity has been remarkable.
No, that's great. Does anyone have any, I guess would love to get, 30 seconds on what your biggest learnings are from this pandemic?
I take away the power of what's possible when we are forced to reframe our thinking and to put both the individual patient and the collective communities we're serving front and center. It has accelerated our ability to look and say, have we really been using our resources the best way possible? And I believe fee-for-service has driven healthcare in a way that's not allowed enough time to spend with people, to not be comprehensive, to not reward outcomes versus units of care. And so I think the takeaway from COVID is we were forced to change. We've got glimpses of what type of value can be produced. We've seen, just Dr. Mansfield just said, if we just say what's possible, we're so ingrained in our current system and the way we have to care for people that we can do it in a very different way with better outcomes, as well as making our systems work better, take stress off of the teams that are at frontline taking care of people, which we absolutely have to do. Bottom line, as it says, we have to work not just as health systems, but we have to work as communities with systems coming together to manage the population and serve all of us.
Beautifully said, Dr. Moore. Power of possible. I think that's the word. Power of possible, power of solidarity. So thank you for all your efforts. I think you are like healthcare heroes you've managed at a level that it's been pretty inspiring to see the load and the pressure on the healthcare workers. So big thank you.
Thank you.
I think the healthcare community is thankful for everybody that's come together to help healthcare do what it can.
Great. Dr. Mansfield, any parting?
Just the one simple insight that I always like to share whenever given the opportunity is, so working in the ED, you can either become really jaded, really cynical because of some of the horrible things that you see and some of the horrors that humanity can do to each other, or you can take the flip side and take it as a reminder every day that you have no idea how much time you have left. And if you just take it from that lens and look at all of your decision making and your behaviors and your relationships from that perspective, COVID is a daunting task and we continue to tackle it. But I think that we've encouraged our teams to look at it from that way. And we have intentionality in finding moments of joy because, again, you don't know what's going to happen tomorrow. And COVID will be there tomorrow and it'll be there the next day. And so what are you doing to find joy? So I hope that that's something that our teams have heard loud and clear. I know we'll keep shouting it from the mountaintops, but I would just like to share that perspective because it's otherwise an overwhelming conversation that's never ending. And I think as an ER doctor that I'm the most fortunate that I get that reminder on a regular basis to savor those moments. So I would just encourage everybody to keep that in the back of their head.
You know, it's also, with what you just said, it reminded me again of the ER gives us a reflection, if we can pause and look backwards and saying, why did this situation end up in the ER? And what can we do moving upstream? What does it tell us about what needs to change? And that's, I think, a big part of our takeaway as well.
Great. Thank you so much, all of you. And thank you for all the great work that you are doing. And thank you for actually ending on that very inspiring note, despite, it seems like gloom and doom all the time these days. So thanks so much for this session. And I believe there will be a recording available as well for people to replay. Thanks.
Thank you.